All right, next is a super fun topic and is very important for especially my interns out there or anyone seeing patients in the emergency room, is the acute abdomen. So first off, what are the signs of an acute abdomen? Well, we always say there's rebound, rigidity, and guarding on the exam. But the first thing and the most important thing always is vital signs. So this patient is maybe tachycardic, maybe tachypnic, maybe hypotensive because they're in septic shock from their perforated viscus. Who knows? Okay, so always, always, always vital signs. There's a reason why they're called vital signs. Then you examine the patient. They're distended. They have positive rebound. For those of you that don't know what rebound is, when you push down and you let go, they have more pain. That's a very indicative sign of peritonitis. Something bad's going on inside the abdomen. They have guarding. They don't want you to touch that area. And the abdomen can be rigid, okay? So all these things are telling us that we have an acute abdomen and signs of what we call peritonitis, okay? So then a fun exercise here that we kind of do with anybody, and I probably missed some of these because, my God, the students always do this. So we kind of break the abdomen up into different areas. And so let's talk about some of the common things that will cause this in each area. Right upper quadrant, guys, hit me. So gallbladder, probably the most common. Acute cholecystitis, right upper quadrant pain, Murphy's sign. For you guys, answer some questions about what that is. That's going to be common. Any liver pathology, so maybe like ascending cholangitis, someone would maybe say. That's going to be like your big player. And then in the epigastrum here, or the left upper quadrant, we think more stomach or spleen. So any splenic things like a splenic infarct, splenic abscess, that's rare though. But what's going to be more common is like any pathology in the stomach. So peptic ulcer disease, a perforated peptic ulcer would obviously be kind of the worst case scenario in the left upper quadrant or epigastrum. Those are like my main things I'm thinking about here. There's of course too the goose, the esophagus up here. So I want you guys to help in the comments and come up with some other diagnoses of your own, but I'm hitting the important ones. The appendix, obviously, come on down to the right lower quadrant. And then the important question is like, are we with a male or a female? Because then we have to think about ovaries on either side here or testes either side down here. And then of course we can have inguinal hernias here and here on either side as well. And then over here I'm thinking like diverticulitis. And then in the middle too we have a bladder. So cystitis, things like that. Any of the things over here too, colon pathology, the entire stomach's going to have all your small bowel pathology. But again, these are like the major players. We don't want a testicular torsion, ovarian torsion. Those we need to identify right away. Again, I want you guys to really feed off of this one and fill out the rest of this for me. But those are going to be my big players, and you cannot miss the vital signs and the physical exam findings. Because what's the first rule? First thing, well, I have a lot of rules, but first rule is trust no one, and first rule two is always go see the patient. Everyone will always tell you that. We had a scenario recently where the student was getting a consent ready for me, and I happened to walk by the patient's room. No one else went and saw the patient. It was for a tracheostomy, and they were extubated like an hour before that, right? So rule one, see the patient, trust no one. Those two go hand in hand. Give me more diagnoses, please.